So you have been in the boob business. You have been in breast augmentation or breast reconstruction business. I know that isn't all that you do.
Right.
But for close to 3 decades.
That's right.
So let's talk about what the changes you have seen when breast reconstruction after breast cancer surgery began in the late 60s or 70s. What were you seeing?
Well, I started in this business in 1981, and breast reconstruction at that time was primarily done with a flap of skin and muscle from the back, which was rotated up into the front, and then a breast implant was placed under it to give volume. And that was the state of the art at that time. A little bit later, tissue expanders were invented. These are, in a sense, implants which are empty and which are placed in an area adjacent to a defect, or even in the breast case right under the defect, and then gradually filled so that expansion takes place, the skin is stretched, new skin is formed, and eventually, just like a woman who has a pregnancy over 9 months, the abdomen stretches out and expands, and actually skin is generated. The same is true when we put an expander under the breast tissue. It's just over a faster period of time. And then later the expander is taken out, a new implant is put in, and a nipple reconstruction is done, and we have a new breast. All of that was started after I started in practice. The third thing was the development of new flaps. And there was a flap called the tram flap, which is a use of the abdomen, actually the part of the abdomen, abdominal tissue that is thrown away in a tummy tuck, can be used to form a breast. And I remember when I first saw this procedure and assisted on it, it took almost all day to perform one tram flap. Now we do it in less than 3 hours by ourselves. And that's just, it's just experience and knowledge and learning mistakes to avoid and so forth. It's typical of new operations take much longer. I remember heart bypass surgery used to take all day, and now it takes a matter of hours to do. And then the fourth thing was the use of the microscope and doing microsurgical procedures, whereby a piece of tissue can be taken from one part of the body, preserving the blood vessels to that part, and attaching those blood vessels somewhere close to where the breast is going to be, usually in the armpit or maybe out of the chest wall. And those vessels are anastomosed, put together, so that new blood flow now occurs into the flap. And so tissue can be moved from one part of the body without keeping the vascular leash that we used to have to do. So those are the major new techniques that have taken place in breast reconstruction since I've been here.
Okay. Wow, that is a lot.
Yeah.
That is. You know, I've heard women, and I've said it myself, you know, when you stand and look at yourself in the mirror naked and you think, if I could just take part of this and put it up here and move things around, and actually that's what the technology has done.
Yes. In fact, the newest technique that's making rounds, and it's still controversial, is actually harvesting fat from one part of the body and injecting it or grafting it into the breast to add volume.
I'm so glad you brought that up, because I was going to ask you about that. I've read an article recently about that.
Yes.
And that is just incredible. So actually a woman can regrow her own breasts.
Well, I wouldn't exactly call it regrow, but the premise is that when we harvest fat cells, and if we harvest them safely so that the fat cells aren't damaged, and then we place them in a rich environment with good nutrition, then those fat cells, being living cells, will continue to grow, just as a hair follicle will grow if you move it from one healthy area to another area. The problem is sometimes the fat cell is damaged when it's removed, and sometimes it is placed in an area that doesn't have rich blood flow, or if a large amount of fat is placed in an area, only the outside cells will have the blood flow and the inside cells will not, and they'll die. Well, the criticism of using fat in breast reconstruction was that when fat necroses, when it doesn't survive, it will sometimes calcify. And when that happens, one can develop lumps, and even calcified lumps, which mimic breast cancer. Well, that's the last thing you want to put in someone who's just suffered from real breast cancer. And it's also the last thing you want to do in a young person who has never had breast cancer, but will forever be, every time she has a mammogram, be told that you have a problem area here, we need to go biopsy or to look at it. So some of those things need to be, it needs to be really safe, and it has to be reproducible and so forth. And so we're at a very early stage of that, learning new ways to harvest the fat safely and learning the physiology of safely transferring it somewhere, avoiding those pitfalls. And even at best, it will never be able to augment a breast the way an implant can in terms of size. It would be a modest enlargement. We are already successfully using fat transfer in the periphery of a breast. Say an area where a woman has an implant but is very thin, and maybe some rippling occurs where you can feel or see the folds of the implant. Some fat grafting in those areas will thicken that skin and make the rippling better. So it does have some practical applications even now, but to really augment, I mean, that requires quite a bit of fat.
Right.
It's been researched also in the use in the bottom. You know, there are some women and men, I guess, who just don't have much of a derriere, and would like to have more of a Brazilian-like bottom.
Right.
And so fat grafting may be a use there as well.